Good morning and good afternoon to all of our friends and colleagues in the United States and around the globe. It's my pleasure and privilege to welcome all of you today and introduce our colleague, Dr. Mary Beth Sexton, who is a fellow in infectious disease at Emory University. Dr. Mary Beth Sexton completed her training at Columbia University and came to Emory University to do infectious disease training. Dr. Sexton has written 2 chapters related to infectious disease, and I have very much enjoyed reading those chapters, and accordingly asked her and my colleague, Dr. Nadine Raphael, if Dr. Sexton would give us a lecture on sepsis in the surgical patient, with particular attention into the cardiac surgical patient. Having read her chapters, I felt that the lecture could just very well be applied to any patient in the intensive care unit, not only a cardiac surgical patient. With that in mind, Dr. Sexton, please proceed.
Thanks so much, Dr. Latouf. Good morning, everyone, or good afternoon. So I'm going to talk today about sepsis, particularly in cardiac patients, but as Dr. Latouf said, this does apply to anyone in the intensive care unit. One of the reasons we would focus on this in cardiac patients is that patients with underlying cardiovascular disease have a couple of issues related to sepsis. One is that they are probably more at risk for infections, partly because when they're hospitalized, they often need invasive monitoring, everything from Foley catheters in the setting of patients getting diuresis for heart failure, to central lines, to pulmonary artery catheters. And then when they do require cardiac procedures and surgeries, those carry an infection risk as well. There's also some evidence that patients with underlying cardiac problems have a higher risk of complications when they do get infected. And then in the setting of sepsis, resuscitating these patients creates some challenges with hemodynamic monitoring and fluid balance. So what we'll talk about today is very briefly just the definitions of sepsis and septic shock, and then turn to talking about how we should think about working these patients up in terms of their history, the exam, and the kinds of tests we send, and then move on to talking about the initial management, both with fluid resuscitation and initial antibiotic choices. So I think of the progression from SIRS, the systemic inflammatory response system, to sepsis, to severe sepsis, to septic shock, to be a continuum where there is some overlap, but we're trying to get at people being increasingly ill and having increased risk of organ damage and tissue hypoperfusion. So people who meet SIRS criteria have at least 2 of those 4 things wrong. Either they're tachycardic, they're tachypnic, can be either hypothermic or febrile, and they have some sort of abnormality in their white count. Either it's less than 4,000, it's greater than 12,000, or they have more than 10% bands. Historically, we used to consider people who met SIRS criteria and we thought we knew they had an infection to be septic. More recently, they've broadened that definition a little bit to consider anybody where you know they have an infection and they have at least one sign of systemic illness. That could be a SIRS criteria, or that could be things like they have altered mental status or they're oliguric. We consider that severe sepsis when they go on to have organ function abnormalities, like they have acute kidney injury or they have evidence of tissue hypoperfusion. And then that becomes septic shock when those things aren't responsive to giving them appropriate fluids. When we think somebody might be somewhere on that continuum, the goal is picking it up early, finding them when they're at the stage of meeting SIRS criteria or early sepsis and not when they're already in septic shock. So we'll talk about some of the things we use to do that. One of those is fever, which can be very helpful to us as an early indicator that somebody has an infection. The 2 things to keep in mind are that in an ICU patient, there are a lot of non-infectious causes of fever, everything from they have a DVT or a PE to they're having drug fever in response to something they're receiving, but also to think about the fact that not all patients who are critically ill are even capable of mounting a fever. So people can have a normal temperature and be septic in the setting of renal failure, particularly dialysis, especially CRRT in an ICU. Patients who are on ECMO often won't mount a fever. Patients with heart failure who are elderly are less likely to. So those are all situations where you have to have enhanced suspicion. When you do have a fever in somebody who's critically ill in the intensive care unit, the first thing you are trying to figure out is, are they infected, or is this from something else? And if you think they have an infection, it's to figure out where it's coming from, and then what kind of organisms you need to be worried about. Is this somebody who came in from home and has never been in a hospital, or is this somebody who's been in the ICU 5 times this year and really could have something very drug resistant? So you need to know if they can tell you or their family can tell you what symptoms are they coming in with, what's their medical history, particularly have they been infected in the past, have they been on antibiotics recently, are they allergic to anything, have they been in the hospital, do they have or have they recently had a central line, a Foley catheter, do they have a pacemaker in, have they ever grown a resistant organism? And just thought I'd share, this was a recent case I saw on our consult service here where that history was enough to make the diagnosis of what was going on with the patient. So somebody I saw in their mid-60s, dilated cardiomyopathy, and listed for heart transplant. They had been on milrinone, in the process of adding dobutamine for increasing instability. And so the team in the intensive care unit really wanted a pulmonary artery catheter in to check the pressures. The issue was that every time they had tried to put one in, the patient spiked a fever. And what was weird about that was those fevers were coming within 12 to 24 hours of the line going in. And that's early to really attribute the infection to the line. The other thing that was odd was that every time they had tried to do this and the patient had had a fever, they'd gotten blood cultures. So there were actually 10 sets of blood cultures in the preceding 2 weeks, and none of them were growing anything. So their question to us was really, what's going on? Is this person infected? Is this a really odd presentation of a line infection? Are we having to add additional vasopressive and inotropic agents because they're septic, or is this just that the heart failure is getting worse? So when we reviewed the chart, we discovered they had been at another hospital 8 months prior, and at that time they'd had a pocket infection of their pacemaker ICD device, and the cultures had been positive for staph. So they had appropriately gotten an echo, which did look like there might be something, either a clot or a vegetation on one of the device leads, and it happened to be the device lead right next to the tricuspid valve. The issue was the patient was too unstable to go through device extraction, so the patient had gotten 8 weeks of antibiotics, but they hadn't had a subsequent transesophageal echo, and so our theory was that they actually had either remaining clot or a sterilized vegetation, given that the cultures weren't growing anything, that was now sitting on the tricuspid valve, and that every time the team tried to place the PA catheter through that valve, they were probably showering small bits of whatever was left on that valve, and the fever was probably an inflammatory response. So the conclusion was patient probably was not infected but could not have a line. So they actually got listed 1A with exception for heart transplant as a result of finding that history, hopefully saving them from further embolic phenomena. There are cases, though, where the history is not enough to help you, and that's when the physical exam becomes really important, and it should be targeted to what you think you're looking for. The first thing is the vitals. Do they just have a fever, or are they otherwise unstable? So this person whose vitals are here is somebody I saw who came in with fever, heart rate of 69, systolic in the 1-teens, at least not septic yet. Although what was notable on the monitor here is the T waves. This actually was a person with peak T waves, a creatinine of 8.5, who had a fever because their potassium was also over 8 in the setting of renal failure from their autoimmune disease they were coming in with. So sometimes even the very early vital signs help you. The thing that's notable though is the blood pressure needs to not get checked just once in somebody you think might be septic. There are studies looking at the risk of progression to septic shock, and some of the people who look worst are people who have what we call non-persistent hypotension, where their blood pressure is going up and down, which may lead people not to be as careful, and sometimes those people progress quickly. So the blood pressure monitoring needs to happen more often in somebody you're worried about. In terms of the physical exam then, I like to think about this head to toe so that I don't miss anything. So starting generally with the neurologic exam and an overall sense of the patient's mental status, this can be really hard in the ICU. They're often sedated, intubated, can't communicate with you, may be altered for reasons other than their infection, they may be delirious, but you do care about the mental status as much as you can assess it, as well as their level of consciousness. And then you'd be really worried if you could identify focal deficits. And the final thing there is particular attention to anyone who has an intracranial device or a recent procedure, like the person in this picture who has an extraventricular drain in place. You would want to palpate the whole way along that track, make sure that it wasn't indurated, make sure it's not red, make sure they're not draining, look at the output from the drain, make sure it doesn't look like pus. In terms of then looking at the HEENT exam, the thing of particular concern in the ICU with a fever you can't explain is often sinusitis, because patients in the ICU do tend to have risk factors for it. Anyone who had a nasotracheal intubation or who has a nasogastric tube in, like the dummy in this photograph, are at risk, or anybody with facial trauma. The trouble is that the diagnostic criteria you would use in an outpatient office, things like drainage from the sinuses, headache, facial pain, ear pain, cough, are often absent in somebody who's altered or intubated. So you need a high index of suspicion, and if you keep coming back to this as a possibility, it's when you think about getting samples and imaging. The cardiac exam is also important, as we'll talk about in a minute, because differentiating between septic and cardiogenic shock in somebody who has underlying cardiac disease is difficult. But what you're looking for here is, particularly in somebody you think might be progressing along the sepsis continuum, do they look like they have decreased perfusion? Are they cold? What does their cap refill look like? Are they, like in this picture, actually becoming cyanotic? And then you care on the cardiac exam, particularly about a new or worsening murmur, because in the right setting, that might tip you off about endocarditis. Additionally, in the rare case that you've got somebody who's actually a heart transplant patient, if you suddenly got a gallop, you may be worried about rejection. In terms of the lung exam, this is often really difficult in the ICU. Somebody's intubated, they can't cough for you. It can be very difficult to get good breath sounds if you can't move the person easily, and when you're hearing the vented breath sounds over the patient. But your focus is, are they equal bilaterally? Do you hear anything focal? Do you have increased secretions or sputum production? In this picture, somebody is developing an infection partly of the skin around their trach site, but you're also looking for what the tracheal secretions look like. Do they look purulent? The abdominal and urinary exam, you're looking for, do they look uncomfortable? Are they guarding? Do you have any rebound tenderness? Talking with the family, the patient, the ICU nurses about whether they're having diarrhea. The urinary symptoms are really challenging in the ICU because a lot of people will have a Foley catheter in. But you do want to look at the urine and the Foley catheter, both at the output, and sometimes it being cloudy or purulent looking can tip you off, but often you're going to need to do further investigation. And then finally, but very importantly, is in somebody you can't explain a fever, to do an incredibly thorough head to toe look at the skin and the joints. because sometimes you get surprised. First of all, most importantly, do they have a line in, and what does it look like? You can certainly have a line infection where the line site looks totally normal, but if it's red or draining or indurated around the line, it's a big tip-off. You also want to see, do they have any signs of a problem with their perfusion? Like, are they throwing emboli? Do they have anything that looks abnormal? And then finally, looking at the joints, do you have any signs of effusion? Are any of them warm? Do you have trouble ranging any of the joints? Especially if you know they have prosthetic material, you really want to focus there. Once you've done the exam, there is some lab testing that can help you in making your diagnosis. And there's some things that you should send in everybody you're worried about, and then there's some things you should really target to what in particular is bothering you about the exam and the history. So everyone who has a fever or concern for sepsis should have at least 2 and preferably more sets of blood cultures. The problem in the ICU is it's very easy to draw a set of cultures off the line, and often these patients are very challenging peripheral sticks, especially if they're volume down. But if you draw a culture from the line, you really want one drawn peripherally too. It helps to differentiate between things that are contaminants and things that are real. You also want to lactate in everyone you're worried about for a couple reasons. First, it's just helpful in making the diagnosis of sepsis. If somebody has an elevated lactate and they meet SIRS criteria, the specificity of that for sepsis is pretty good. How elevated the lactate is also matters. There was a study that looked at people who came into the emergency room, and people who had a lactate over 4 when they came in were 5 times more likely to progress to septic shock. And then, as we'll talk about later, the lactate's also helpful for seeing how well you're doing at treating the sepsis as you follow it over time. In selected patients, then, you want some other tests. So if you have somebody who has increased secretions or cough, or their lung exam is abnormal, then you want a sputum culture. And if this isn't somebody, this is somebody who's intubated and can't cough, you can do an aspirate from the endotracheal tube, better done without sending saline down the tube first, partly because it dilutes the sample and partly because you may wash things that are just colonizing the endotracheal tube into your culture. A urine culture is reasonable in anybody who has a Foley catheter and a fever. C. diff testing is reasonable in anybody who has diarrhea in the ICU, especially if they got antibiotics in the last 2 months. But even people who didn't, it's probably worth sending. We do see community-acquired C. diff occasionally. And then the least common thing to need to send would be a thoracentesis culture. A lot of patients in the ICU have small effusions that are not the source of their fever or infection. But if you've got an effusion that you could tap at the bedside in somebody who has an associated infiltrate or who got instrumented recently or had trauma that could have introduced organisms, then you definitely want to send that. The things that we see get sent a lot that actually aren't that helpful are bacterial stool cultures and stool ova and parasites. The reason those often aren't that helpful is bacterial and parasitic diarrhea are almost never acquired in the hospital. There are exceptions. There have been hospital-associated outbreaks where you'd want to send them. And then the other exceptions are if this is somebody who came in from home and landed in the ICU from the emergency department and has been having diarrhea at home, you'd probably want to check those things. Or if they're very immunocompromised, so AIDS patients and transplant patients, we work up differently and would send those things. In terms of imaging, a chest x-ray is almost always indicated if you have a fever in an ICU patient, especially if they're intubated, but probably regardless. The question of when you want to get a CAT scan of the chest is a little more difficult. If you have a lot of suspicion, but the chest x-ray is negative, it's probably worth it. a lot of our ICU chest x-rays are portable. They may miss things at the lung bases, and the chest CT is better for things that are smaller, like pulmonary nodules. So if you had somebody immunocompromised who you thought could have something fungal or something mycobacterial, you would really want it in that setting. And this is an example of that. This was a patient of mine who, other than being hypoinflated on that chest x-ray, fairly normal. The accompanying chest CT, though, shows a lot of peripheral pulmonary nodules, including at the lung bases, that were missed on the CAT scan. This was somebody who had disseminated MAC. Other imaging is needed less commonly for particular targeted indications. You want a CT scan of the head in anybody who's got fever and focal neurologic findings, especially if you think you might get a lumbar puncture. The CT of the sinuses, like we talked about earlier, if you've got high suspicion for sinusitis and somebody who you can't really elicit symptoms, then you want to get that imaging. And the CT is preferable to the X-ray. It lets you see what's going on better. So that workup that we just talked about, the history, the exam, those labs and imaging, pretty much holds true for anybody who spikes a fever in the intensive care unit. There are a couple of additional things to focus on in cardiac patients. So we'll talk first about people who recently had a procedure or surgery. If they spike a fever after a cardiac cath, a valve replacement, bypass surgery, the length of time from when they had that procedure to when they have the fever matters for how worried you are. People who spike a fever within 48 hours of the procedure, it's far less likely to be an infection related to the procedure and much more likely to be post-op fever. When you get to more than 72 hours out, then you're really worried about an infectious complication. And in the middle is a little bit of a gray area where you use your judgment and the results of your workup. The one exception to that is that surgical site infections with organisms that cause necrotizing infections, things like Clostridium perfringens or group A strep, those can come up much more quickly than your average surgical site infection. So it's not that if you saw erythema and purulent drainage from your site in 36 hours, you should certainly worry. It doesn't mean this never happens. It's just less common. So the things you want to look at are their access site, either if they had groin access for a cardiac cath, if they've got a sternal wound incision. You're looking for, is it red? Is it painful when you palpate around it? Is it indurated? Is it draining pus? If you have any of those things, the most important thing to do is actually not antibiotics. It's to open the wound and wash it out and to get deep cultures while you're doing that. Everybody should have blood cultures in this situation and deep wound cultures if you do open the wound. Just swabs of the superficial surgical site, even if it's draining, are not that helpful because they tend to pick up skin flora in there too, and then we don't know what's real in terms of what's deep inside the wound and what's just the patient's skin flora. The chest x-ray and the urinalysis are less likely to be your source. The exceptions to that would be if somebody is clearly coughing or if somebody's had a Foley catheter in place for days and now they have a fever, you would work that stuff up as we talked about. Patients who have a central line or a cardiac device are another category to be particularly careful about. In terms of the central line, if they have one and they have a fever, it's immediate blood cultures. You're much more worried about the line as the source the longer it's been there, but this can happen even in people who've only had a line for a couple days. In the event that the patient is crashing during your exam, you identify the line, you don't have another clear source, you want to pull it right then and there. If you've got somebody who's septic and you do the rest of the workup, they're not hemodynamically unstable, but they're clearly a potential risk, and you can't find another reason, you also want to pull the line in that setting. And a lot of times you can send the tip for culture. Sometimes that helps identify your bug, even if you don't get it on blood cultures. The cardiac devices are another issue. So there's always some risk of infection with any foreign material, so pacemakers and ICDs fall in that category. That does seem to be increased in people who are immunocompromised. They seem to be more likely to get device infections. So anytime somebody has a fever, you want to look very carefully at the pocket site. The reason for this is sometimes the device is the initial source. Sometimes it caused your problem. But the issue is if the patient gets bacteremic for another reason, like for example, they get a line infection, they can then secondarily seed the device. So you need to look carefully at the device site. And in somebody who has proven bacteremia and a device, you need an echo to make sure you haven't seeded the device leads or the heart valves. The final thing is people who have prosthetic material, whether this is prosthetic heart valves, an aortic graft, like in this, you can see on this chest x-ray. They need targeted evaluation for the same reason as the cardiac devices, that the prosthetic material could be your source, or it could have gotten seeded in the setting of whatever else is going on. So these are people that you're going to very carefully work up for endocarditis. And this is something that you'll see as you go through your exam, where you're looking for some of these things that would tip you off. The blood cultures and the echo being the most critical things you can do to look. This is where an ophthalmic exam can be helpful. If you see conjunctival or retinal hemorrhages, it may mean you're throwing emboli from a source, either a graft or a valve. Looking at the skin, making sure you don't, as we talked about earlier, have any evidence of arterial emboli. Looking for things like Janeway lesions or Osler nodes. I've only seen them a handful of times, but they are very helpful when you find them. Looking at the urinalysis and the creatinine, because if you throw emboli to the kidneys, you'll often have blood in the urine, and you can even see AKI associated. If they've got any kind of pulmonary symptoms, the chest x-ray can be helpful here because you can throw septic pulmonary emboli. And then if somebody you suspect of having endocarditis or device or material involvement and they're altered, you want to image their head because you can throw emboli to the brain as well. So once you have looked at this whole workup with a particular focus on the things that you need in somebody who's a cardiac patient, this question is still often not resolved, which is, does this person in front of me look awful because they're septic, or do they look awful because they're in worsening cardiogenic shock? The problem is sometimes the answer is both, and it can be very hard to tell them apart, especially if the person doesn't have a fever. The issue here is there's been a lot of work recently done looking at cardiac dysfunction in sepsis, and there's a lot of evidence that the left ventricle does not pump like it should in people who are septic. So you can see both systolic and diastolic dysfunction in these patients, even if they don't have underlying cardiac issues, and so particularly in people who do. But this is a case, particularly if you're in the ICU, where hemodynamic monitoring is very helpful. People who are septic do tend to have decreased systemic vascular resistance and to have their central venous pressure be low. Because of those things are low, these people often get tachycardic, and so their cardiac output does go up in sepsis often. The issue there is that if they have not been volume resuscitated, the cardiac output will still be down, which can fool you a little bit. The lactate, like we talked about, is also helpful. Theoretically, it'd be up in either one of these etiologies because it's reflective of poor tissue perfusion, which you have in any kind of shock. But if you do have the lactate elevated and the patient meets SIRS criteria, then you really are pretty indicative of sepsis. If you get to this point and you really think the patient is septic, the most important thing is to act on this early. So the initial study on this that's famous is the Rivers study it was published in 2001 in the New England Journal, where they looked at a very protocolized intervention for sepsis designed to get these patients early and aggressively. There's been a lot of work since that time on whether it's really adhering to the specific Rivers protocol that's so helpful, which does involve dobutamine as the pressor and early blood transfusion in a lot of these patients. There have been studies where they looked at, rather than following that exactly, just following an algorithm that the institution uses with early response, aggressive fluids, and that seems to be equally helpful. So it really seems to be the attention called to sepsis and early response rather than exact following of those steps that's so critical. So the Surviving Sepsis Guidelines were most recently updated in 2012 using that information, and they recommend doing what you need to ensure that the patient's MAP is at least 65, that their CVP is in the 8 to 12 range, that you've got a mixed venous oxygenation over 65%, and that they're at least putting out a 0.5 ml per kg of urine per hour. And so the critical thing to accomplishing that is aggressive fluid resuscitation. And then the recommendation is for addition of vasopressors within 6 hours if you're not having response to blood pressure. The studies where there was a delay of 14 hours or more in adding pressors had significantly worse mortality outcomes. And following lactate levels here is a secondary recommendation, but important for seeing how well you're doing. There was one study that showed for every 10% you improved lactate clearance, your mortality risk dropped by 10%. So it certainly is an important indicator. This, though, comes up in cardiac patients as a concern, partly because their mortality has been shown to be higher. This study that's noted on the slide here, patients who had had an arrhythmia that required medication, a prior MI, a recent cardiac cath, had almost 3 times the mortality of people who had no significant cardiac history in the setting of sepsis. So you could argue that that means these people are even more important to jump on early and aggressive. But the issue that comes up of concern is that, especially in the heart failure patients, when you're talking about aggressively fluid resuscitating them, this concern about causing pulmonary edema, and it's certainly a valid concern. So there was a study that looked at this. They looked at a big group of people with sepsis, about a quarter of whom did develop adult respiratory distress syndrome, a lot of whom required ventilation. And they looked at the group who developed ARDS and the group who didn't, and the proportion of those two groups who had heart failure was the same. So it didn't look like having heart failure increased your risk of ARDS. And the authors of that study actually argued that likely because you were preventing worsening hemodynamic compromise, that aggressive fluid resuscitation in everyone may prevent ARDS. So at this point, as all of this is going on, as you've done your evaluation, you've decided you think the patient's septic, you're responding to their blood pressure and hemodynamic indicators, it's also critical to start antibiotics early. The issue is it's also important that they're the right ones, which is challenging because it's often a day or two before you really know what your source of infection is and what your organism is. The problem is, one study looked at patients' initial antibiotic selection and found that about 20% of the time we do this wrong, and the patients we do this wrong in do have higher mortality. So the choice has consequences. It'd be lovely then if we had universal guidelines. If you think they're septic, give them this. The problem is that's really difficult to do too, because the correct antibiotic depends on where you think their infection's coming from. Does this patient have allergies and they can't get certain antibiotics? Are they at risk For drug-resistant organisms, these are the people coming from long-term care facilities, the people who've been in the hospital 6 times this year. The patient's culture data, for them, there are people who have a history of MRSA or a drug-resistant Pseudomonas, and you've got to cover that if they're coming in septic. And then finally, the antibiotic resistance patterns in the hospital you're in matter. There are places that don't see a lot of MRSA. There are places where almost all of their Staph aureus is MRSA. And so in individual hospitals, antibiogram matters when you pick antibiotics too. So very briefly, we'll talk about some general guidelines, but keeping in mind that this all does depend on those criteria. If you think the patient has a urinary source, particularly people with a catheter, what you're worried about is that organisms from the skin or fecal bacteria got introduced through the catheter. So this is going to be things like E. coli, Klebsiella, Enterococcus, you can see Pseudomonas. And so you want to make sure whatever you pick empirically is going to cover that. So this is going to be things like the fluoroquinolones, depending on the antibiogram in your institution. At Emory, at this point, Levaquin is pretty useless for this, but there are places where that's not the case because there's not as much resistance. The 3rd and 4th generation cephalosporins, the extended spectrum penicillins like piperacillin, tazobactam, the carbapenems, although those are big gun antibiotics where you'd want to be sure you had a reason, and an aminoglycoside, possibly with ampicillin if you're thinking about Enterococcus. And then the other important thing is if this is somebody with a catheter, to get it out as soon as possible. If you think you've got a lung source, particularly in somebody where you're going to have to cover for healthcare-associated pneumonia or a ventilator-associated pneumonia, then you really are worried about resistant bugs. So in this case, you want something that's going to cover for gram-positives, things like staph and strep. And because you do want to cover for resistant staph, this probably needs to be vancomycin or linezolid in somebody who's in the ICU. And then you're going to add to that coverage for gram-negative organisms, things like Pseudomonas and Acinetobacter. The reason we talk about double coverage here is that a lot of those organisms have increasing resistance. So the thought is that if you give somebody 2 different antibiotics, you have a better chance that you're covering whatever they have. You can back this off as soon as you know what it is. So this is going to be things like a beta-lactam, beta-lactamase inhibitor, things like their piperacillin, tazobactam, a carbapenem, a cephalosporin that's going to be either one of those that's going to be active against Pseudomonas. So that means not ertapenem, not ceftriaxone, you want cefepime. And then, so you pick one of those 3 things, and then you can add to it either a fluoroquinolone, again, that has activity against Pseudomonas, or an aminoglycoside. If you're worried about the line as the source of the infection, basically what you're worried about is skin flora, things like staph and strep. If you know, based on your institution's antibiogram, that MRSA is a problem, vancomycin is your best empiric coverage. In terms of whether you need to add anything to it, that depends on the patient. If they are crashing in front of you, if they're neutropenic, if they've previously grown a drug-resistant bug, then you probably want to add similar gram-negative coverage to what you added for pneumonia. And then finally, if you think you've got a suspected cardiac device infection, staph is your main culprit in these cases, either Staph aureus, can be MSSA, MRSA, or coag-negative staph from the skin. We do see Propionibacterium, Carini, and rarely but possibly gram-negative organisms. These are usually in people where something a little strange has happened. I saw a Stenotrophomonas pocket infection once in somebody who was shooting drugs mixed in tap water. These are not things that the gram-negatives you don't tend to see in the average patient, but they should be on your radar if the patient's not getting better on your antibiotics. Usually empiric coverage with vancomycin in these cases. And then the most critical thing is, does the device need to come out? This is always a question, especially in the people where it's risky to take it out, like the people whose ICD fired in the last 6 months. But the people we really think about this in are if they're bacteremic. There's data that people who get bacteremic with Staph aureus and they have a device, 50% of them seed it. So especially if you have staph bacteremia and you don't know where it came from and they have a device in, and then if on the echo you're seeing a vegetation on the device leads or the valves, certainly. And then if you have what looks like more than a superficial pocket infection, like if the device or the leads are eroding through the skin, if you're draining pus, if you have an abscess in the pocket, those are all times when the device should come out. So in looking at this, my main takeaway is that it's really important in looking at the patient to identify that they're septic early, to recognize the vital sign issues, to recognize your likely source, and then to go after it aggressively, to use your history and your exam and your labs to help point you in the right direction. But regardless of whether you know what's happening, to aggressively fluid resuscitate and to start empiric antibiotic therapy with your best guess about where your source is and very broad if you don't know where that source is. And then from the infectious disease doctor perspective, what we also always like to harp on is that once you do know what your source is and you've identified your organism, like if somebody has MRSA pneumonia, they don't need to keep getting piperacillin and tazobactam. They can just get the vancomycin. So when you can safely de-escalate antibiotics, you should. And then the other important thing is that in these people who do have devices in, who have a central line, who have a Foley catheter, to keep looking at them every day and to make sure that that device needs to stay in, because those things should all come out as soon as possible. All right. So if anybody has any questions at this point.
Dr. Sexton, thank you very much for a great lecture. Any questions from the audience, you may type and send the questions, or you may speak up to the microphone and ask the questions. Dr. Sexton, you have given us an outstanding lecture, and you spoke to audience at the University of Jordan, at Hebron University in Palestine, at the Arab Hospital in Amman, at Specialty Hospital in Amman, at colleagues at Ohio University, at Arkansas, and a number of cities across the United States. I'm getting a comment from Dr. Ali Haq, says a fabulous presentation, and from Dr. Osama Hamid, who compliments you about a great lecture. Dr. Heval Kelly, great lecture. Thank you very much for your time.
Thank you.
I know Ms. Isra had a question that you wanted to ask. Are you still online? Okay,
Yes.
there's a question from the University of Jordan. Dr. Sexton, thank you for your excellent talk. How much do you rely on procalcitonin as a diagnostic and follow-up marker? Procalcitonin. This is from Dr. Amjad Benihani, my colleague, cardiothoracic surgeon.
So I have not personally used it a lot because where I trained for residency, it was a send-out lab, so it would come back a week to 10 days later. And so at that point, it was academically interesting, but not clinically helpful. We get it back a little more quickly than that at Emory. My feeling is that it never makes my decision for me. Like if I really don't think somebody is infected and that's elevated, that doesn't change my mind. But I think it can be helpful if you're on the fence, particularly in people where you're maybe waiting on going ahead with a procedure or a surgery until you make a determination that they're not infected. If I thought they weren't and that came back negative, it would certainly make me feel better.
Okay. Another question from the University of Jordan. For how long do you treat medial stenitis following coronary artery bypass? And this is from
So
Dr.
in those patients, so in those patients, hopefully they are able to get washed out because that's the most important part of that is to be able to clean out that infection. But then I usually am looking at 4 to 6 weeks of antibiotics, depending on the situation and how successful washout was.
Okay, great. Any other questions? I know this has been a terrific presentation and raised a number of great questions. We're beyond our allotted time. Dr. Sexton, we thank you for the time that you have given us in presenting an outstanding lecture, and I thank all the participants for joining us and for raising wonderful questions. One more question from the University of Jordan. If all of the cultures are negative and the patient has fever, low-grade fever, and the echo is negative, what is the next step? This is from Professor Mahmoud Abu Abila, Senior Cardiac Surgeon at the University of Jordan.
So this is always the really difficult situation. This is the one where, we get called in and everybody puts their heads together, and this is where sometimes going back and repeating the exam reveals things. Like I've had people where we were stumped on the source of fever, and then in looking at their arm, all of a sudden you could palpate a cord where they'd had an IV in a week earlier and they had a septic thrombophlebitis. So sometimes a really thorough exam, you pick things up again. But in the people who keep having fever and the cultures are negative, there's no clear source presenting itself, the echo is negative, that's when you start thinking about occult abscess. Do you need to get a CT chest, abdomen, pelvis? It's a little bit patient dependent what you're worried about in those situations, but those are the really frustrating, difficult ones. Those are cases too where if the patient has been on empiric antibiotics, I often will stop them just in case you've now moved to seeing drug fever. Occasionally in those people, depending on how long they've had a fever, I will get a viral swab because we've had people get flu or other respiratory viruses while they're in the hospital. And sometimes you've been stumped for a couple days on what's causing the fever, and it turns out that their visiting aunt gave them flu. But there's not, unfortunately, a definitive algorithm for how you proceed in those people because it is a little patient dependent on what you're seeing and what you're worried about.
Okay. Dr. Tariq raised a question. Thank you very much for a nice presentation. Is there a time limit to the removal of a device, or is it occurring to a patient? I presume if you have an evidence of infection in a device, is there a time limit for device removal?
So it depends a little bit. I mean, ideally, so if the patient is hemodynamically unstable and you think the device is the source, it needs to come out as soon as possible. If you have a device infection without that kind of hemodynamic instability, like if you think you've got an ICD pocket infection where you want to remove the device, ideally, again, you'd get it out as soon as possible. We do see the scenarios where we have somebody who we think that extracting the device is potentially going to be life-threatening. And in those cases, we're very clear about the fact that this is not ideal, but we're going to leave the device in place and treat through with antibiotics as a trial. But those are just always cases where everybody from the team to the patient needs to be aware that that's what's going on and that this would not be ideal, but it's what you have to do. But if the device can come out, I usually like to see them come out within 72 hours. That's not guideline specific or designated anywhere, but people usually seem to do better with source control, similarly to surgical infections.
Dr. Sexton, you're generating a lot of questions. Dr. Haval Kelly is asking, what is your thoughts about the rise of new genetic testing to detect early sepsis and antibiotic resistance?
So I think a lot of that is really exciting. My research is on carbapenem-resistant organisms, which we often go 72 hours to 4 days before we know that's what we're dealing with.
Yes.
So some of these new technologies where they're talking about 4 to 12 hours to be able to identify your organism off of blood cultures are exciting. I think the issue is that it will be difficult to know how early and easy that will be to go widespread. I think there'll be a while before some of that stuff is uniformly available. And so I think it would be a shame to lose some of our other diagnostic skills, some things about the exam and the history that you can use anywhere and everywhere. But I do think some of the microbiology lab technology that's coming down the pipe in the next couple years is really going to change some of these algorithms. I think we're going to be able to de-escalate antibiotics a lot more quickly, and we may not have to do as much work on figuring out what should be given empirically because we may know very quickly, like after a single dose, what we're looking for.
Good. Dr. Sexton, Dr. Tariq from Specialty Hospital sends his thanks and regards. Dr. Hival Kelly from Emory, Dr. Zaid Ammari from Ohio, Dr. Osama Hamid from Arab Hospital in Amman, Professor Mahmoud Abu Abila, and Professor Amjad Abu Hani from the University of Jordan, and Dr. Osama Hamid from Arab Heart Center, and our colleagues at the Hebron University send their regards and appreciation for your lecture. Thank you very much, and thanks to
Thank you
all,
very much.
and we will sign off. Goodbye, everybody.